Hello, and welcome to today's webcast, Proper Antibiotic Use in Senior Living. I'm Lois Bowers, Senior Editor of McKnight's Senior Living, and I'll be your moderator. In efforts to minimize the risk of antimicrobial resistance, it's important to help residents and their families understand the appropriate use of these drugs and what they can do to ensure that antibiotics work when they're needed. That's why we're pleased to have Nancy Losman, Senior Director of Quality at Omnicare, a CVS health company, with us today to share 9 core messages for consumers about preventing antibiotic resistance, including guidance from the Centers for Disease Control and Prevention about the smart use of antibiotics. We'll hear from Nancy in a few minutes, but first we have some housekeeping matters to take care of. First, I'd like to let you know that today's slides are not available for download. And if you think you're experiencing audio difficulties with this broadcast, please first check the volume control on your computer. We found that this is the most common cause of hearing issues with presentations like this one. The sound should come from your computer speakers. There is no call-in number. If the volume control doesn't appear to be an issue, then please click on Test Your Connection. Please also keep only one browser window open on your computer to prevent echo. Also, we will have time for questions and answers at the end of today's presentation. If you have any questions about the information presented, please feel free to send them directly to us at any time during this hour by clicking below. This educational offering has been reviewed by the National Continuing Education Review Service of the National Association of Long-Term Care Administrator Boards. It has been approved for 1 clock hour. Please note that you must stay tuned to this event in its entirety during its original broadcast to receive a certificate. You'll be asked to answer 2 confirmation questions during the live webinar. Then you'll be able to click on Get My CE below to obtain your certificate. We'd also like to note that this program is made possible by support from Omnicare, a CVS company. You can visit the website at omnicare.com to learn more. But remember, do not interrupt this webcast presentation if you would like to earn the CE credit. And finally, this session will be archived and available on demand shortly after this live broadcast. You can access this webcast again at no cost, and others can experience it for the first time, again at no cost, by simply going to the registration page to enter this studio. Use the link sent to you via email or go to this website address, mcknightsseniorliving.com/September11webinar. As I mentioned, however, accrediting bodies dictate that CE credit may be given only for attendees at this live broadcast. Now I'd like to tell you a little bit more about today's featured speaker. Nancy Losman is a consultant pharmacist and chief quality officer for Omnicare, a CVS company, and is a pharmacy services provider serving more than 2 million long-term care admissions annually. She holds an adjunct faculty appointment at the University of the Sciences in Philadelphia. A certified consultant pharmacist, Losman has certificates in gerontology and pharmacy regulations. She has lectured on topics including the use of MDS by long-term care pharmacists, medication safety and error prevention, nutrition, Medicare reimbursement, and adult immunization. Losman is a fellow of the American Society of Consultant Pharmacists and chair of the ASCP Foundation. She has been a member of the Pharmacy and Therapeutics Committee of ProVantage Prescription Benefit Management Services, a Wisconsin-based pharmacy benefits management company serving more than 4 million people. Losman represented the ASCP to the Long-Term Care Professional and Technical Advisory Committee of the Joint Commission for 5 years and was the chair of ASCP's Educational Advisory Committee from 1999 to 2001. She currently is the chair of the Antimicrobial Stewardship Steering Committee of the ASCP. She also is a member of the Clinical Practice Committee of AMDA, the Society of Post-Acute and Long-Term Care Medicine. I can't wait to hear what she has to share, and I know you can't either. So with that, I'm going to turn things over to Nancy to begin her presentation. Nancy?
Well, thank you, and good afternoon, everyone, and a good morning to you who are calling in from the West Coast on this solemn anniversary of 9/11. As we begin to enter into the busiest season for antibiotic prescribing, we want to take a look at how we can embrace antibiotic stewardship and what senior living communities should do or could do becomes a very timely topic. And while there's plenty of guidance from the CDC regarding long-term care and senior living communities, we're not bound by any singular regulation, such as skilled nursing facilities. So with that, what I want to do is, in this presentation, is take a look at our uniqueness as assisted living, as both an industry and at the community level, to see what we can individually decide the next steps we can take to help keep antibiotic resistance low, help our residents stay well, prevent not only infections but also antibiotic resistance. So today's objectives include defining antibiotic stewardship and antibiotic resistance, building a community team to evaluate the utilization of antibiotics in residents in your community, structuring a strong message to residents and to families about antibiotics that are not always clinically indicated, and work with referral sources in your community's efforts to minimize antibiotic resistance, and to help with those referral sources that you have by telling your strong message about preserving antibiotics for when they're really needed. As we all know, antibiotic resistance is one of the most urgent public threats, and every year in the United States, at least 2 million people are infected with antibiotic-resistant bacteria that are very difficult, if not impossible, to treat, and 23,000 of those will die as a result of that infection. But antibiotic resistance does not mean that the body is becoming resistant to the antibiotics. It really means that the bacteria is becoming more resistant to the antibiotics that was designed to kill them. When bacteria become resistant, antibiotics can't fight them, and bacteria begin to multiply, and some resistant bacteria can be even more difficult to treat and spread to other people, such as our other residents, our staff, and family members and visitors. When we take a look at the overall risk of antibiotics, the first thing that we should really be looking at is the antibiotics adverse events. The two most prominent that are always considered an adverse drug reaction is the prevalence of C. difficile or Clostridium difficile after using antibiotics, as well as Candida. Clostridium difficile each year affects nearly 500,000 people, and 15,000 people die because of antibiotic-induced C. difficile infections. Candida happens when a person's microbiome or the normal flora in their mouth and gut are disrupted when they're taking antibiotics. There is an increased risk for a fungus or yeast infection, such as Candida species, and there are common types of Candida infection that are usually vaginal or found in the mouth and the throat. These infections, especially in seniors, can become serious and become systemic. Our residents would have to be hospitalized. In addition to adverse drug reactions, other risks of antibiotic use are allergic reactions. They can range from anywhere from a mild rash and itching to life-threatening swelling in the face and throat, known as anaphylaxis, and a call to 911 and an immediate action for discharge to the hospital. Additionally, drug interactions are very common with antibiotics. Antibiotics can interact with other drugs to either increase the antibiotic blood levels or increase another medication's blood levels or even decrease that drug's levels. One of the most important interactions for all of us to be aware of, and we've all experienced it in healthcare, is when an antibiotic is prescribed in the presence of warfarin, and all of a sudden we see that the resident has increased bleeding. So again, those risks should be understood so that we are able to communicate them to our residents and to their family members. Antibiotic resistance is also an adverse effect of antibiotic use. It happens when a patient takes an antibiotic and the bacteria that it's fighting adapts to the antibiotic and develops new resistance. The resistance can become very difficult for our patients to be treated. And as a matter of fact, when you think about antibiotic resistance, the two most historical highlights of antibiotic resistance happened way back in 1962. When methicillin was released, it only took 2 years for Staphylococcus to become resistant, and now we have the common infection, hard to treat, MRSA. In 1996, it only took 1 year for pneumococcus bacteria to become resistant to levofloxacin, and this is why this is a very urgent issue in the United States. When our residents need an antibiotic, we want them to work. And to do that, we have to minimize or de-prescribe antibiotics in our population. So as we take a look at the goals of addressing antibiotic use, of course, all of us want to improve patient outcomes by reducing unnecessary antibiotic prescribing and reserving the antibiotic for when it's really needed to avoid side effects, adverse drug reactions, rashes, and other problems associated with antibiotics. Decrease C. difficile infections, which can be deadly, especially in seniors. It's said that if we reduce antibiotic prescribing by as little as 10%, we could lower C. difficile by 17% in the community. We also are looking to decrease antibiotic resistance. Preventing infections and improving antibiotic prescribing alone can save 37,000 lives from antibiotic-resistant infections over 5 years. And of course, we'd like to decrease the cost. Not only the cost of the antibiotic, but the overall cost of care associated with difficult-to-treat resistant infections. So we need to prevent them, and there is no shame in making the tracking of our costs one of those outcomes that we're looking for in addressing antibiotic use. So the CDC has given us 4 strategies to combat antibiotic resistance. The first one, of course, is preventing infections and preventing the spread of resistance. Second, tracking infections and antibiotic use. Third, improving antibiotic prescribing, also known as antibiotic stewardship. And the fourth, developing new drugs and diagnostics. Well, I don't think there's any one of us on the phone that is about to develop a new drug or a new diagnostic. But certainly we can take a look at how we can prevent infections and resistance, how we can track them, and how we can improve antibiotic prescribing in an assisted living community. To help prevent infections, first and foremost, we should begin our immunization programs and make them robust, offering immunization to residents, to staff, and to visitors. Annually offer influenza. Remember, People 2020 set a goal of 90% of Americans vaccinated for influenza by the year 2020, and 90% of seniors vaccinated with pneumococcal vaccinations, and 30% of seniors being immunized against zoster. The second thing that we can do to help prevent infections is, of course, infection control practices. Always hand hygiene being first. Personal infection control programs for residents, keeping in mind that we're caring for residents who may have difficulty in activities of daily living, have difficulty cleaning themselves when they use the bathroom and then washing their hands, We also have a large contingent of residents with cognitive disabilities who need to learn to participate in their own infection control program. Additionally, especially at this time of year, we should remind our residents about droplet precautions, sneezing into tissues or your elbow, covering up your cough, and how to dispose of tissues in the community. Managing outbreaks should they occur in your community, and other types of actions that your infection control manual probably has an abundance of to assure we're not spreading infections among our seniors. Some tracking examples, the second leg of improving antibiotic use, takes a look at the things that we can do from a practical perspective. So, for example, we can track the number of new antibiotic starts every week in your community, and then total them up by month, total them up by year. We can count the number of antibiotic therapy days used in your community and compare them month over month, year over year. We can certainly count the number of new move-ins who come into your community already using antibiotics. We can count the number of antibiotic prescriptions that don't have a diagnosis on them and don't have a reason for use. And we can count the number of antibiotic prescriptions without a stop date or a defined duration of therapy. These are just 5 examples of manageable tracking regarding antibiotic use that can happen in our communities. The definition of antibiotic stewardship and what we should be doing there was defined by the Infectious Disease Society of America, the Society of Healthcare Epidemiology of America, and the Pediatric Infectious Disease Society as coordinated interventions designed to improve and measure the appropriate use of antibiotic agents by promoting the selection of optimal drug regimens, including dosing, duration of therapy, and route of administration. The dosing in our population is very important, as many of our seniors do not have the renal capacity of a younger person and generally will require lower doses, especially of some of these high-risk antibiotics that they are using. Unfortunately, the definition that CDC has applied to a long-term care facility is such: nursing homes, skilled nursing facilities, and assisted living facilities collectively are known by the CDC as long-term care facilities. The CDC recognizes that about 1 million residents who live in assisted living communities, and that we treat 1 to 3 million infections per year in assisted living communities. That means that we're looking at 1 to 3 infections per year per resident in long-term care. Infections usually include in our communities urinary tract infections, diarrheal diseases, including bacterial and viral, and antibiotic-resistant staph infections, among others. Infections are a major cause of hospitalization and death for assisted living, and as many as 380,000 people die of infections in long-term care facilities every year. So is an antibiotic stewardship program beyond the scope of senior living? When you talk about infection control, data collection, collaboration with prescribers, a liaison with your referral hospital or referral long-term care skilled nursing facility. Do we have the human resources? Do we have the education? Do we have the tools that are required to, in a practical way, approach antibiotic stewardship in assisted living facilities? Well, according to the CDC, they say everyone has a role to play in improving antibiotic use. What they're telling us is that we need to talk to residents and families about when to use antibiotics and when they're not needed. All of us has come to know a family who insists that every time mom feels a little stuffy or has a sore throat or has a small cough, that we should get an antibiotic on board, that we should send her out to the doctor and she should have a prescription. Well, that may not necessarily be so, and that's a difficult conversation to have with some of our family members, but it needs to be done nevertheless. We also have to ask residents if they have ever had C. difficile. You know, there's usually a recurrence of C. difficile in 30% of residents, or 20 to 30% of residents in 30 days. And additionally, it can recur later with the next antibiotic use. Additionally to that, what we need to do is make sure that we are about conversing with the awareness of antibiotic resistance in long-term care facilities and communities, and helping us understand the data that is available to us. For our residents, what we need to be telling them is an array of different topics that includes talking to their healthcare provider about when antibiotics are used and when they should not be used. Talking to our residents to talk to their healthcare provider about how to relieve symptoms associated with colds, for example, that don't require antibiotics. Our residents should ask what infection the antibiotic is treating. We want to know exactly, is it a urinary tract infection? Is it an upper respiratory, lower respiratory infection? That should come back on their prescription or the note to the community from the prescriber. We should advise our residents not to save antibiotics for use later. I've come across folks in assisted living facilities that always save a few of those little extra pills that are in the bottom of their antibiotic vial so that they can take them at a later date. Insist that everyone cleans their hands before we touch one another, and that includes our residents asking your staff to clean their hands before helping them, and that we should all stay healthy by keeping others healthy, by cleaning our own hands. Our residents need to be able to know what to do when they're covering coughs, stay in their room or apartment when they are sick and contagious, and most importantly, they should definitely get their influenza vaccinations. So, what are some of the other roles that need to be helping us and those that we can reach out to in terms of supporting antimicrobial stewardship and minimizing antibiotic resistance in communities? Well, there are healthcare systems, hospitals, clinics, and your referral nursing homes. Understand what they're doing to minimize antibiotic use so that we can assist them, support them, or even copy them. Healthcare providers and professional organizations need to lead the way and support each of us with the tools, education, and expertise that we need to manage antibiotic resistance. Contact federal, state, and local agencies. I will tell you that in assisted living, there is nothing that you need to create. The CDC has done a remarkable job with not only tools for professionals, but tools for residents, tools for patients, tools for family members, tools for staff members. And of course, insurance companies can help by trending their claims and following their residents, their patients through the healthcare system to see where we're failing when it comes to infection control and appropriate antibiotic use. Now, when you take a look at the next slide, this is the CDC core elements of antibiotic stewardship for long-term care, keeping in mind that they define long-term care as including assisted living facilities. These are strong elements. So these take a workload to get done and a great team to accomplish the effect. It requires leadership, which we commit to safe and appropriate antibiotic use, and that we have a written statement in the nursing home regarding antibiotic stewardship. that we are held accountable and we identify the physician, nursing staff, and pharmacy leaders as being responsible for promoting the judicious use of antibiotics, that there's drug expertise and that you can rely on a consultant pharmacist, that we should take action and implement at least one policy or practice to improve antibiotic use while we track and monitor antibiotic use with regular reporting and feedback into the quality assurance program, and to provide educational resources not only to staff and residents but also to other clinicians and families. That is quite a tall order for assisted living facilities that may not have the human resources or financial resources dedicated to these core elements. So when I examined the other types of settings that are out there, reviewed core elements for other healthcare settings, it appears to me that assisted living at a minimum can embrace the core elements of antibiotic stewardship for outpatient settings. So listen to the difference. The commitment here is to demonstrate dedication to and accountability for optimizing antibiotic prescribing and patient safety. That is, open up a dialogue between you and the resident, you and their prescribers. Implement at least one policy or practice to improve antibiotic prescribing and assess whether the work is helping and if we need to modify it. Track and report antibiotic prescribing practices and offer feedback to providers, or have providers assess their own antibiotic prescribing practices themselves. And education and expertise, we can provide educational resources to providers and patients on antibiotic prescribing and assure that that expertise optimizes antibiotic prescribing by partnering with your pharmacy provider or the physicians who work with a good number of your residents. I think that this is a much simpler outline of core elements for assisted living, and it's something, as they said, we can embrace because we all have a role in antibiotic resistance and preventing it. So when we take a look at inpatient and long-term care health providers, we're going to ask physicians to follow clinical guidelines when prescribing antibiotics. How many times have we heard that a resident has brown, smelly urine, and without testing it, without physically examining the resident, an antibiotic is prescribed over the phone? And we should ask prescribers to remember when they're prescribing for our residents that these are seniors. We want the right antibiotic at the right dose prescribed for the right duration and at the right time to assure that the schedule is such that we can actually administer or aid our residents with receiving medications appropriately and at the right time of day. Review antibiotic therapy 48 to 72 hours after it's been initiated. By that time, if there was a culture and sensitivity that was taken in the doctor's office, we might call the physician to see if a new antibiotic is going to be prescribed or if indeed the bacteria that we're treating is sensitive to the antibiotic that was prescribed. It's a pretty critical step in care, but it is the follow-up that we can use to assure that our residents are on their right path to health and wellness. Talk to patients, talk to families, talk to residents about when antibiotics are and are not needed, and discuss those harms such as the allergic reactions or C. diff and antibiotic-resistant infections. And be aware of antibiotic patterns in your community and use the data to inform prescribing decisions. So, for example, if you see a resident that's been treated for an infection for 5 days, and then the next time they need the medication when they have the same infection for 10 days, and the next time the doctor prescribes it for 14 days, do we have the right drug? Are we really treating an infection that needs an antibiotic? Is this the right antibiotic to treat the resident? Or is the microbe becoming resistant to the antibiotic that the prescriber wrote for the resident? So when we take a look at some very fundamental guidelines. We're going to review just two. There are an array of prescribing guidelines for infections, but I'd like to bring your attention to two of the more common, simpler types of guidelines. This one is called the Loeb Guideline. It is for suspected skin and soft tissue infections, and it requires, before an antibiotic is prescribed, that the wound or the soft tissue has pus from a wound, from the skin, or from the soft tissue site, and at least two of the following: a fever, redness, tenderness, warmth, or new increasing swelling. So just because there is pus, I also need to have other information available. And this is the type of assessment that we would expect nurse practitioners, physicians, physician's assistants, and nurses to do before they refer the resident for an antibiotic to the prescriber. Another easy guideline is the Loeb Guideline for a suspected urinary tract infection for someone who's not using an indwelling urinary catheter. The symptoms here would be that they should have acute dysuria or a fever and at least one of the following: urinary urgency, frequency, suprapubic pain, blood in the urine, side tenderness or flank tenderness, or urinary incontinence. Again, meeting this minimal criteria even before referring the patient to the doctor for the need of an antibiotic. Sometimes acute dysuria can be treated simply by additional fluids and perhaps cranberry juice. So there are messages for consumers that I think that you should be aware of, and it's one of the really important areas and objectives of this particular lecture. First, we have to remember that the CDC wants us to communicate to consumers, as they do, that antibiotics save lives, and when a patient needs them, even though we know that their side effects or adverse drug reactions, the good outweighs the bad. That antibiotics aren't always the answer. Everyone can help improve antibiotic prescribing, and improving this among healthcare professionals will really minimize antibiotic resistance and ensure that antibiotics work when we need them. The third message: antibiotics do not work on viruses such as colds and flus. And antibiotics are only needed for treating certain infections caused by bacteria. Sometimes you will have a bacterial infection such as bronchitis and sinus infections, or even some ear infections, that are not treated by an internal antibiotic. Antibiotics will not make you feel better if you have a virus. Continuing the messages: when antibiotics aren't needed, they won't help you, and the side effects could still hurt you. Taking antibiotics creates resistant bacteria. Antibiotic resistance occurs when bacteria no longer respond to the drugs designed to kill them. If you need antibiotics, take them exactly as prescribed. And stay healthy and keep others healthy by cleaning your hands, covering your cough, staying at home or in your apartment when you're sick, and getting all of your recommended vaccines. For example, the annual flu vaccination, where we should all be having our flu clinics underway now. So there are some questions, however, that the CDC is telling your customers they should be asking you about your facility. And I think it's pretty important for us to understand what the CDC is trying to do there. And we should all be sitting down with these questions, I think, and formulating very good responses. So for the first question, and you would imagine you're sitting on move-in day, and the family is with you, and they're about to drop off their mother and father to live with you for hopefully the rest of their lives. These are the questions that they're asking their children and their responsible parties to ask you. What infections commonly occur among residents in this facility? When was the last outbreak? And what caused it? Was it a norovirus or food poisoning? Did the facility request assistance from the public health authorities or other partners for your outbreak? How did your facility communicate with residents, families, and visitors when you had an outbreak? Is the flu vaccine mandatory for your staff working here in the senior living community? And what percentage of your staff received flu vaccine? Right now, we're looking at about an average of 63% of nursing home and long-term care staff receiving their flu vaccine. We need to push that number. If a staff member is sick, is he or she allowed to stay at home or go home from work without losing pay or time off? How are facilities trained to respond to questions about hand hygiene from residents and from family? Number 7, are residents with new diarrhea given separate toilet facilities here until the cause of their diarrhea is determined or the diarrhea is resolved? How is shared equipment, such as objects in your therapy areas or common rooms or dining rooms, managed to prevent the spread of germs? Does your community have private rooms for residents who develop signs or symptoms of a potentially contagious infection? And does your community provide education materials for residents and for families about hand hygiene, the use of personal protective equipment, or antibiotic use? These are pretty important questions, and the CDC knows exactly who their audience is, and that is the children of the seniors coming into our communities. These are some good questions to ask ourselves to see if we have the answers and we're able to prove to the next customer coming into your door that we have the capabilities to communicate, to educate, to treat, and to prevent not only infection, but antibiotic resistance. November the 12th through the 18th is the United States Antibiotic Awareness Week. It's annually observed, and it helps to raise the awareness of the threat of antibiotic resistance and the importance of appropriate antibiotic prescribing and use. According to the CDC, up to 50% of all antibiotics prescribed to people are not needed and are not optimally effective as prescribed. They may be the wrong antibiotic for the bacteria we're trying to treat. And antibiotics are also commonly used for promoting growth in food animals, which is one type of antibiotic use that's not necessary. I'm sure that some of you already have had questions about, do you have non-modified types of organic foods that you're serving? Are you purchasing your chicken from farms that don't use antibiotics for growth? And as the younger generation, younger than the seniors in senior living, shop at Whole Foods and Wegmans and other organic markets, they're starting to bring these questions into assisted living facilities, and the CDC is urging them on. So celebrate Antibiotic Awareness Week. There's plenty of materials that are available from the CDC that you can download and promote your facility in this celebration. Let's take a look at a couple of those. We can engage residents and gain their support in whatever antibiotic stewardship program you would like to use. Upon moving, and at least annually, we can provide communication to residents and families and responsible parties about our efforts to contain antibiotic use. We can address the expectations of staff and family by discussing that we are only going to promote antibiotic use based on real clinical need and not just when someone thinks that they should have an antibiotic. Explain to the residents that, we have these ongoing efforts. We're trying to reduce not only costs, but the side effects, the adverse drug reactions, the drug-drug interactions, and the cost that are associated with unnecessary antibiotics, preserving them for when they're really used. And how can you promote the appropriate use of antibiotics during U.S. Antibiotic Awareness Week? Well, you can distribute educational materials that you pull down from the site to residents and to families. You can highlight U.S. Antibiotic Awareness Week on your website by creating links or putting up a banner. You can deliver presentations to interested parties like families and residents. You can include content in your employee educational materials during this week in November. Distribute tools and guidelines to healthcare professionals that you work with who are prescribers for the residents in your community, and collaborate with the CDC and local level programs on projects with your community to embrace the wise use of antibiotics in community living. So at this, I know you have questions and we have plenty of time. So in summary, let me say this. The core elements designed for long-term care that are posted on the CDC website may exceed some of the resources that we have in assisted living. But it's not to say that we cannot assume our proper role in reducing antibiotic prescribing, tracking infections, tracking antibiotic use, and improving communication with healthcare providers, prescribers, nurse practitioners, urgent care centers, clinics in your neighborhood, your referral sources, your local hospital, to assure that you can take part in the conversation and not only improve your referral sources, but quite frankly, maintain the census in your buildings by judicious antibiotic use, by implementing just some of the few tips that the CDC has given us, and by preparing the responses to the 10 questions that a consumer might have for you regarding how does your facility manage antibiotic use and infections. So with that, we can open it up to any questions that you may have, and I'll turn it over to our host.
Thank you, Nancy, for all that great information. I'm sure listeners are looking forward to implementing the strategies you shared at their communities. And as you mentioned, we'd like to open it up for questions now. We have several already, but if you have any additional questions for Nancy, please feel free to type them in below, and we'll get to as many as we can. The first one we have is, what is the acceptable course of treatment for a resident with C. diff who continues to test positive for culture?
Okay, that's a great question. And really what we're not doing is testing for cultures anymore, but there are new updated guidelines for the treatment of C. difficile, and they're changed. And I think that you'll see that some of them are safer for seniors. So the guidelines for C. difficile can be downloaded from the CDC. And what we're finding is that older physicians who treat older residents tend to prescribe older antibiotics. So as we're looking at first-line therapy for some of these, it's still maybe vancomycin oral capsules or solution. There are some new products that are commercially available as a solution. They may be expensive. We may run into some coverage issues. But again, the treatment guidelines are modified and changing with some considerations not only for seniors but for payment.
All right. And then another question is, should an antibiotic be prescribed to treat UTI symptoms before the UA or the CNS is obtained? And if not, isn't the patient or resident susceptible to becoming septic?
The best thing that we can do is if you believe that a resident has a urinary tract infection, you can either take a clean catch sample if you have availability of the lab to come to your community and pick up the sample, or assure that you send the resident to the doctor and they take the sample first before initiating the antibiotic. When you initiate the antibiotic, it certainly is not going to give us a clean report in terms of what may or may not be there or the number of microbes that are seen or visible in the urine. Remember, keeping in mind the lobe guidelines and checking for the fever and the rigors and those types of things that are associated with a urinary tract infection, but you want to get that clean catch before the antibiotic is initiated. And a lot of communities are beginning to do bedside testing to assure that there is bacterial protein in the urine before they even send the resident out to the physician or have the physician come in or nurse practitioner come in and see the resident. So there's a couple ways to go here, but first rule of thumb is don't mess up the culture by providing the antibiotic before the sample is taken. So the minute you suspect a urinary tract infection, grab the sample and then go ahead and begin treatment. Check in 48 to 72 hours the results of the culture to assure we have the right medication at the right dose and at the right frequency.
Okay, great. Another question we had, would you please speak to the need for closer monitoring of INR during antibiotic treatment?
Yes, thank you. There are a lot of medications such as ciprofloxacin and sulfa medications that interact with warfarin and increase bleeding. So it's not all anticoagulants, and the rule of thumb would be that within 3 days, an INR is taken for residents who are using warfarin and an antibiotic to assure that we can adjust the warfarin easier than we can adjust the antibiotic. So we would either hold the warfarin for a few days or lower the dose, whatever the prescriber would determine is necessary for that resident. But generally what you want to do is get an INR within 3 days of the initiation of the antibiotic.
Okay, great. Another question is, what happens if a family member or staff member in an assisted living community refuses to get the flu shot?
Well, there's a couple of things that we can do, and one of those is herd mentality. And that is, while we have some people who will never, and that's why never want to get a flu shot, and that's why even the 2020 goal is only 90%, not 100%. If the rest of us are immunized, then we're pretty well protected, we feel. However, for those that refuse the flu vaccine who are coming into our building, you want to ask them to stay away when they feel sick, although flu is contagious before even the symptoms come upon us. So again, you want to ask them that if they're not going to get immunized with influenza vaccination, that they monitor themselves and please don't come into the community if they are sick or think they're going to be sick or have been exposed to flu, because they don't know whether they're going to get it. So they can be exposed today, visit you tomorrow, come down sick, and they've already brought flu into the building.
Are there any antibiotics which across the board should not be given to people older than 65? There's
really nothing that's off the table dependent on the bacteria that needs to be treated. What we do, however, is take a look at kidney function, body size, age, and alternate the doses. So, for example, you might have someone that has a MRSA infection and they require vancomycin, but their kidney function is not the best. We can either lower the dose or lower the interval at which the medication is given. So if somebody was, let's say, any antibiotic was prescribed at 500 milligrams, the pharmacist and the physician can work to perhaps lower the dose based on the statistics of the resident to 250 milligrams. Or they could stay with 500 milligrams every other day. So the pharmacokinetics and the pharmacodynamics can be worked out between the physician and the pharmacist to monitor the dose of a required antibiotic. Of course, we'll always have high-risk antibiotics like vancomycin and the aminoglycosides, and we carefully monitor blood levels when we're using those infusion products. But I will tell you that we've seen some remarkable adverse events with drugs like levofloxacin, where it has caused confusion in some of seniors. So while there's none that say don't use in seniors, we're going to modify the dose, but first and foremost, we need to treat the infection, and we'll do that wisely and judiciously using pharmacokinetics and pharmacodynamics.
Okay. And here's someone who says she's seeing a trend to use Vaseline on scraps, suture sites, skin tears instead of triple antibiotic ointment. Is this a new trend?
Well, there's a couple things to say here. One, never use a topical antibiotic on a wound that's not infected. So if someone has a skin tear, I often see that they're running the triple antibiotic ointment, and then putting Tegaderm or something over it. If it's not infected, it doesn't require an antibiotic. As far as wound healing, there are claims that creams can promote healing. We all know that a wound that is kept rather wet dries without scarring better than those that are dressed dryly, but you want to consult a nurse. Certainly pharmacists know our drug products, but we're not wound care specialists. Vaseline may help keep a wound moist, and it may help with scaling, scarring, or itching, but certainly that would be up to the physician to determine what should be used. A lot of physicians, especially if there are wounds on the face, use something like an Aquaphor to minimize scarring in absence of an infection.
Okay. Can you talk about any penalties that a facility might face for not having an effective antibiotic stewardship program?
Well, for assisted living, it's going to depend on your state and your regulations and what they inspect in survey issues. I will tell you that regardless whether you're skilled or assisted living, the infection control program in your facility is very easy for any surveyor or inspector to visually see its efficacy. Even I know enough as a pharmacist when I'm in a building, when I see the linen cart open, I put the drape back down. They watch infection control before they get into antibiotic use and antibiotic stewardship. That's going to be the first, unveiling of the fact that there may be a problem. The other thing is, remember, if you're submitting your data for outbreaks to the state, they already know that you may have had one or two outbreaks in your community or your facility, so they know where to look or, what might be happening. And they'll look at the type of infection. If it was a food poisoning versus hand-to-hand transmission of, let's say, C. difficile or another viral diarrhea, they'll know where to look. I have not seen fines or deficiencies for antibiotic stewardship, but I've certainly seen fines and deficiencies for a lack of infection control. If you do not have infection control, antibiotic stewardship isn't going to help you.
Great. And are the questions that you shared that consumers should be asking facilities on managing antibiotics and infections, are those available somewhere?
Yes, they are. You can find those questions in the Antibiotic Awareness Week information and on the CDC website. Let me see if I may have them printed here. And I don't know, is there a way that we could email you? If you give us your email address, we can give you the citation for them, but they certainly are able to be downloaded.
Okay, great. Let's see. Are there any foods that people shouldn't be ingesting during antibiotic treatment, such as milk?
It depends. And where you see the pharmacist will put a sticker on the antibiotic package if the medication is not to be taken with food or milk or antacids. Some of those were the older types of antibiotics, like the tetracycline, that we really used to worry about. And some antibiotics are even better taken with food to minimize nausea and vomiting. So find this sticker that's on the medication and use that as your guide for taking medications on a full empty stomach with milk or without antacids at that time.
Okay, great. And I think this will be our last question. Are there any requirements for physicians to undergo training regarding antibiotic resistance, and what can you do if your facility medical doctor or nurse practitioner are not on board with antibiotic usage?
That is a great question. And the core elements for outpatient practices and hospitals are all there. There isn't anyone who should not be on board. And for each type of organization, the CDC has outlined the core elements and what must be done. Of course, there's a lot of monitoring and physicians reporting the use of antibiotics and infections in some instances, like hospitals. So any physician or nurse practitioner who has hospital privileges certainly should be on board with antibiotic stewardship. And again, this is where your leadership as owner-operators and administrators of communities can engage physicians, even older physicians who weren't trained on antibiotic stewardship when they went to medical school or nursing school, should really see, based on the statistics that are out there, that we all need to embrace the judicious use of antibiotics.
Right. Well, we do have more questions. Unfortunately, we've run out of time, but this obviously was a very important issue, and really thankful that you're here to answer the questions we did have and present all of the information that you did today, Nancy. We really appreciate that. And we hope everyone out there enjoyed today's webcast and found the information useful. Remember that the session will be available shortly to listen to again online. So if you'd like to listen to it again, or if you think a colleague would benefit from this information, please write down this web address, mcknightseniorliving.com/September11webinar. Or you can use the link that was sent to you when you registered. Please remember that accrediting bodies dictate that CE credit will be given only to people who attended this live broadcast. Again, we'd like to give special thanks to Nancy Losman for sharing information with everyone today. And we'd also like to thank our sponsor, Omnicare, a CVS Health company. You can visit omnicare.com to learn more. Thanks for everyone listening today. Your questions really were outstanding, and I'm sure help fellow listeners gain an even better understanding of this topic. Once again, thank you for tuning in. This is Lois Bowers for McKnight's Senior Living.